we are now looking at tumors and some changes that actually we see following research in areas of medulloblastoma in ependymomas. We know that it's the most malignant tumor, very uncommon in adults, and because although it is a malignant tumor, if you can remove most of it, and then followed by chemotherapy, radiotherapy, because it is sensitive, you can actually have very long-term survivals, and there are some survivals now reported to be up to 50% 5-year survivals, which is extremely good for a malignant cancer. So the current therapy for medulloblastoma is maximum safe resection. So you take out as much as possible. Then you give radiation therapy to the entire brain and spine in patients more than 3 years of age. Then you follow by aggressive chemotherapy, and sometimes you may actually have to supplement a bone marrow transplant. There is a staging system for the Chang for medulloblastoma called the Chang staging. The more important part of it is actually the metastatic part, because as far as surgery is concerned, whether it's a more than 3 centimeter or less than 3 centimeter, if you remove it, basically the tumor stage actually becomes a tumor 1. So the standard options are surgery. Then you should consider gross total excision, because that increases survival, but surgery by itself is not curative. At the time of surgery, when you send a biopsy, you get what they call small round blue cells, and this would typically be medulloblastomas. They are actually primitive neuroectodermal tumors of the cerebellum, and clinically they are actually quite different in behavior from that of the supratentorial region and from the pineal region. In fact, children with cerebellar medulloblastomas or cerebellar PNETs do much better than some of those with the supracellular PNETs. All right. Now, the other thing that you need to look at today is there are 2 other tumors that previously were considered as medulloblastomas, but they are now classified as different tumors. So one of them is the ATRT, right? Atypical teratoid rhabdoid tumor, and the way pathologists today distinguish these tumors are the lack of expression of NF5 or deletion of the INI1 gene. So this is now a routine test that pathologists do when you send them a specimen, because when the deletions are present, the INI1 is present, it is not a medulloblastoma, it's an ATRT with a different behavior, much more aggressive, very high risk of recurrence and spread. Another tumor is the ETANTR, the embryonal tumors with abundant neutrophil and true rosettes, which is very uncommon, but again now classified as a different type of tumor from the medulloblastomas. Even among the medulloblastomas itself, histopathologically and historically, they have known to be different variants. So you have the classical histology, you have the nodular desmoplastic and large cell anaplastic, and then the medulloblastoma with extensive nodularity. So this is what the classic medulloblastoma is like, with the rosettes that you see, right? The desmoplastic medulloblastomas slightly different. They tend to actually have these areas of lightening of the cell, what they call the desmoplastic features, and they are supposed to have a better prognosis than children with the classic variants, and sometimes they tend to occur in the hemispheres rather than in the foreventricle. Then there's this medulloblastoma with extensive nodularity found in young children, which have grape-like appearance, and they're supposed to have a better prognosis than the classic medulloblastoma. And then, so you can see that actually there are some slightly different appearance, but traditionally all these have been called the medulloblastomas. Now, there's recent evidence to suggest that actually medulloblastoma is not one tumor, but a number of discrete diseases with distinct epidemiology, clinical presentation, transcriptomics, somatic cancer genetics, and outcome. one of the earliest studies before we started doing the microbiology and subgrouping is to look at actually risk factors associated with medulloblastoma. So those that children less than 3 years of age do worse. And the other thing that we were finding was actually high tyrosine kinase C expression. That suggests a better prognosis versus a increased ERB2 expression, as well as MYC, which actually suggests that the prognosis is poor. So these were the initial ways of looking into medulloblastoma, right? Looking at the risk outcome. And then based on some of these, we will then look at the treatment stratification. Maybe if those markers that suggest that the prognosis is poor, you may want to increase the put the patient into a high risk group and then treat a bit more aggressively. Okay, and so risk stratification is something that has been worked out for medulloblastomas. The average risk will be someone with more than 3 years of age. There's no subarachnoid spread, and the surgeon has done a good job. There's less than 1.5 centimeter cube remnant tumor volume. All right, but of course, to try to get 1.5 centimeter cube residue or less, it may come at a price. So some of the complications you see after surgical resection will be posterior fossa syndrome, cerebellar mutism, and also possible cranial nerve deficits, right? And a patient is supposed to be stratified as high risk if it's one of these above, so either less than 3 years of age, or there's subarachnoid spread, like you can see in this case, or the surgeon has left a bigger chunk of tumor behind. Right? And it seems that also and this is a reason is that if you were to remove the tumor, looking at the graphs, and this is actually quite old, 1993, you'll find that actually if you have so-called total or almost near total resection, the outcome is always better than just leaving residue behind, whether you partial resection, do a biopsy, or subtotal resection. Right. So, as I mentioned, it's now considered as a heterogeneous molecular disease. Right? There were some studies, some consensus conference in Boston, which actually they've identified 4 distinct subgroups. There were the WNT group, sonic hedgehog group, group 3, and group 4, and all this differs in the demographic, transcriptional profile, genetic alterations, and the clinical outcome. So looking back at the sort of research that's done from the 90s to 2000, we were just looking at genes, some of the genetic study, and then looking at pathways. Gene studies will be things like Turcot syndrome and so forth, right? And then as we go to the 2010s, we're now using genomics to try to look at various subgroups. And the molecular subgroups now, you can find that actually there are actually 4. Let me just show you. So these are various papers that suggest that the presence of, try to prove the presence of these subgroups. And this is actually a paper by Michael Taylor, which kind of summarized the consensus at the time, that actually there are 4 groups. The WNT group, which is found in older, not infants, but slightly older children. There's the histology is that of a classic medulloblastoma. They rarely metastasize, and in this group the prognosis is very good. And basically you look at how the gene expression is actually the Wnt signaling group, and the chromosome defect that you can find is actually in chromosome 6. Right? Versus then the sonic hedgehog group, which tends to be found in infants as well as in older children, right? The clinical features would be histological. They are the desmoplastic nodular type, and then they commonly do not metastasize, and you can find that actually there are several genetic changes inside them, including the patch gene changes as well as GLC amplification, and they actually is a part of the sonic hedgehog signaling group. Then you have these 2 types, group 3 and group 4, which actually are basically very poor prognosis, and the outcomes are actually not very good in this group. So it depends on which group you can identify, and then you can decide what sort of treatment to offer. Okay. So the beta-catenin status is actually a status that you see in the Win group, and the prognosis is actually very favorable, right? So then there are other ways of actually testing the, looking for the beta-catenin, right? And now we are beginning to re-stratify medulloblastoma differently, right? As I mentioned earlier, right, the advanced prognosis, you have CMIC or NMIC, amplification, anaplastic histology, and then the good prognosis are the nodular ones with nuclear beta-catenin. And then, as I mentioned, the pitfall is that you may actually be seeing a ATRT rather than a medulloblastoma, so your pathologists need to rule out the INN1 mutations, all right? And then, if you are able to identify the subgroups, and increasingly there are now methods that you can do that, you can actually put them into groups and then decide what is the treatment that you can offer, right? There's still research going on, I'll just skip all this, there's still research going on to suggest that actually you can't, people say even if you can identify the subgroups, it may be a bit too early to start personalized treatment based on the group, but there are some studies that suggest that if you are, let me just go up to the next slide. That if you're in the Win group, maybe you do not need radiotherapy. You find that actually, if you look at children with medulloblastomas, even though the prognosis is very favorable, they can survive for several years, many of them actually suffer the effect of radiotherapy. So for instance, low IQ, changes in the endocrine needs, the stunted in their growth, right? And so that's actually a very bad outcome in some ways, although they survive, right? So is there a way to reduce radiotherapy? So it suggested that if you are in the Win group, all you may need is chemotherapy, and that's all, right? So you basically de-escalate the current therapy that we give. If you are Sonic H group, you are kind of average risk. You should actually have chemotherapy, radiotherapy, the tumor bed only, and you don't need to do a full craniospinal axis irradiation, right? There have been the use of these smoothen inhibitors. The problem is that the one that was tried out seemed to work very well for a while, but once the chemotherapy was taken away, the tumor just came back. Then if you are in group 3 and group 4, right, your prognosis is worse. Group 3 more worse than group 4. And so group 4, you probably have a standard risk thing, but for the group 3, if you are identified to be group 3, then you go straight away to high risk therapy, because you know that the low risk therapy, standard therapy treatment is not going to be useful for you. Okay. So that's the current status of medulloblastomas. Okay. Now, quickly going to ependymomas, there are about again up to about 10% of pediatric tumors, right? And they can be either intracranial with the posterior fossa or in the supratentorial region, and some also in the spine, right? Histologically, you have the classic ependymoma, which is WHO2, versus the anaplastic, which is WHO3, right? In the past, again, we've treated it as a single disease, surgery, therapy, but there are now genomic studies that suggest that they are all different tumors, right? So the supratentorial tumor is different from the posterior fossa ependymoma. It is different from the spinal ependymoma, right? These are some of the tests that's been done. For supratentorial tumors, not really so crucial, but for posterior ependymomas, today we actually have identified that there are actually two groups, and some people use the term group A and group B. And group A is basically a group that actually has, they are what we call NAL2 negative and LAMA2 positive, versus the group B, which is NAL2 positive, LAMA2 negative. And the outcomes are actually very different. If you have the NAL2 negative, LAMA2 positive, your prognosis is very poor. Versus if you have a NAL2 positive, LAMA2, so group B, you actually prognosis is very good. And I think you would have had the experience where you have actually a posterior fossa ependymoma, you resect it, it never comes back. When you consider giving some radiotherapy, but it never comes back. Versus another group where you actually take out the tumor, it looks okay, you give radiotherapy, or you observe, and then within weeks, months usually, the tumor comes back with vengeance. And when you go and remove it, is a grade 3. I'm sure most of us have that experience, and they are the ones that do very badly. And it seems that also the location is important. If it's just wholly in the fourth ventricle versus in the CP angle, the outcomes are different. So the NAL2 NAL2 positive, LAMA2 negative group, they do better. The NAL2 negative, LAMA2 positive, they do worse. Okay? So basically, summarize here, right? The location, right? Usually in the younger children, the tumor tends to be lateral, sometimes in a CP angle, all right? And they are LAMA2 overexpression. Versus the older children with a closely midline tumor, all right? And there's NAL2 overexpression, they actually tend to be better prognosis, all right? And then the other one is apparently the problem is not so much in the genes, but in the epigenomic areas, and the CIMP is another marker that actually suggests that if you are CIMP positive, you may actually do worse, okay? And then there's the test looking at DNA methylation, so that the group A are the CIMP, so these are the worst prognosis, versus the group B, which are the CIMP negative. So basically, if you look at posterior fossa ependymomas, there are actually two subtypes, the group A and the group B. The group A, LAMA2 overexpression, don't do well. The group B is a NAL2 overexpression, older people doing better. Okay, so I will conclude here. Thank you very much.
Thank you, Professor Seow.